Question 1. A 68-year-old female presents to the outpatient clinic with a chief complaint of chronic cough. The physician evaluates the patient, orders a chest X-ray and sputum culture, and plans for a follow-up visit after results are back. What is the most appropriate ICD-10-CM code for the patient's chief complaint? A. R05. B. J41.0. C. Z04.89. D. J98.8. Answer: A. R05. This question tests the coding of symptoms and signs in an outpatient setting when a definitive diagnosis has not yet been established. The keyword chief complaint of chronic cough and the fact that further diagnostics are ordered clearly indicate that the physician has not reached a final diagnosis. In such cases, per ICD-10-CM official guidelines for coding and reporting, it is appropriate to code the symptom, which is R05 for cough. An example would be a patient with abdominal pain where the cause is unknown. You would code abdominal pain, not a suspected diagnosis. Always remember to code symptoms when a definitive diagnosis isn't confirmed for outpatient encounters. Question 2. A patient presents to the emergency department with abdominal pain. The physician performs a detailed history, detailed examination, and medical decision-making of moderate complexity. Which CPTE/M code should be reported? A. 99281. B. 99282. C. 99283. D. 99284. Answer: C. 99283. This question evaluates the understanding of emergency department (ED/E/M) coding based on the level of service provided. For ED services, CPT codes 99281 to 99285 are determined by the medical decision-making (MDM) complexity or time, but typically MDM is the primary driver. The phrase medical decision-making of moderate complexity is the key clue, directly aligning with the requirements for CPT code 99283 for ED visits. For instance, if the MDM were straightforward, code 99281 or 99282 would be appropriate, whereas high complexity would lead to 99284 or 99285. Always use the E/M guidelines to match the documentation of history, exam, and especially MDM or time, to the correct CPT code. Question 3. A 45-year-old patient underwent a laparoscopic cholecystectomy. During the same operative session, the surgeon also performed a diagnostic upper endoscopy due to new-onset dysphagia noted preoperatively. The endoscopy was not part of the standard cholecystectomy procedure. How should these procedures be coded? A. For 7562, for 3235. B. For 7562, 43,235 to 51. C. For 7562, 43,235 to 59. D. For 7562, for 3235 XS. Answer: C. For 7562, 43,235 to 59. This question tests the application of CPT modifiers, specifically when two procedures are performed during the same operative session, and one is typically bundled but is distinct. A laparoscopic cholecystectomy is coded as 47562, and an upper endoscopy as 43235. The crucial phrase, not part of the standard cholecystectomy procedure and new-onset dysphagia indicate that the endoscopy was performed for a separate, distinct reason. Therefore, modifier 59, representing a distinct procedural service, is appended to 43,235 to indicate it was separate and not simply an inherent part of the cholecystectomy. Always remember that Modifier 59 is used when a procedure is distinct from another service performed on the same day due to different encounters, sites, or clearly unrelated circumstances. Question 4. A patient is admitted to the hospital with acute exacerbation of chronic obstructive pulmonary disease, COPD. During the hospitalization, the patient also develops acute kidney injury due to dehydration. Which condition should be sequenced as the principal diagnosis? A. Acute exacerbation of COPD. B. Acute kidney injury. C. Dehydration. D. Chronic obstructive pulmonary disease. Answer: A. Acute exacerbation of COPD. This question assesses the understanding of principal diagnosis sequencing in the inpatient setting. The principal diagnosis is defined as the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. In this scenario, the patient was admitted due to acute exacerbation of chronic obstructive pulmonary disease, making it the primary reason for hospitalization. While acute kidney injury and dehydration are significant conditions that developed, they occurred during the admission and were not the initial cause for the inpatient stay. Always remember to identify the condition that led to the patient's admission to the hospital as the principal diagnosis, even if other significant conditions develop later. Question 5. A patient undergoes a colonoscopy that was initiated as a screening but, due to the discovery and removal of a malignant polyp, converted to a diagnostic/therapeutic procedure. What ICD-10-CM code should be reported first for the diagnosis? A. Z12.11. B. D12.6. C. C18.9. D. K63.5. Answer: C. C18.9. This question tests the coding guideline for screening procedures that become diagnostic/therapeutic due to findings. The key phrase, converted to a diagnostic/therapeutic procedure and removal of a malignant polyp, are critical. When a screening colonoscopy results in the discovery and removal of a malignant lesion, the code for the malignancy, such as C18.9 for a malignant neoplasm of the colon, should be reported as the primary diagnosis. The screening code, Z12.11, is no longer primary because the reason for the encounter shifted from screening to treatment of a confirmed condition. Always prioritize the code for the definitive diagnosis found during a screening when a therapeutic intervention takes place. Question 6. A surgeon performs an open repair of an incarcerated incisional hernia, initial repair, without obstruction or gangrene. Which CPT code should be reported? A. 49560. B. 49561. C. 49565. D. 49566. Answer: C. 49565. This question assesses accurate CPT coding for hernia repairs, specifically distinguishing between initial versus recurrent and incarcerated/strangulated versus reducible. The keywords incisional hernia, initial repair, and incarcerated are crucial. Code 49565 describes the initial repair of an incarcerated or strangulated incisional or ventral hernia. If it were a recurrent repair of an incarcerated incisional hernia, 49566 would be appropriate. Paying close attention to descriptors like initial, recurrent, reducible, incarcerated, and strangulated is essential for selecting the correct hernia repair code. Question 7. A patient presents for evaluation of chronic low back pain. The physician documents a history of present illness with 4 elements: a problem-focused exam, and straightforward medical decision-making. What is the appropriate E/M code for this office visit? A. 99202, new patient. B. 99203, new patient. C. 99212, established patient. D. 99213, established patient. Answer: C. 99212, established patient. This question tests the application of E/M coding for office visits under the 2021 E/M guidelines, focusing on an established patient. The key details are chronic low back pain suggesting an established patient, and the documented components, history of present illness with 4 elements, not a standalone driver for E/M level under new rules, problem-focused exam, not a standalone driver, and crucially, straightforward medical decision-making. For established patients, 99,212 to 99,215, the code is determined by medical decision-making, MDM, or total time spent. Straightforward MDM aligns with 99,212, as per CPTE/M guidelines. Remember that for office visits, medical decision-making, or time, is now the primary determinant of the E/M level, not the history or physical exam extent. Question 8. A patient is diagnosed with metastatic carcinoma to the bone from an unknown primary site. What is the correct sequencing for the ICD-10-CM codes? A. C79.51, C80.1. B. C80.1, C79.51. C. C79.51, C7B.00. D. C7B.00, C79.51. Answer: A. C79.51, C80.1. This question addresses the sequencing of codes for metastatic cancer when the primary site is unknown. The core concept tested is the ICD-10-CM guideline that instructs to code the metastatic site first when the primary site is unknown or undetermined. Here, metastatic carcinoma to the bone indicates the secondary site, C79.51, while unknown primary site points to C80.1, malignant, primary, neoplasm, unspecified. Therefore, C79.51, metastatic site, is sequenced first, followed by C80.1, unknown primary. Always remember this crucial sequencing rule: when the primary site of a metastatic disease is unknown, code the secondary site first. Question 9. A patient receives chemotherapy administered intravenously by a qualified healthcare professional. The drug used is 100 mg of a substance that comes in a 50 mg per milliliter vial. The administration takes 45 minutes. How should this be coded? A. J9000x2 units, 96413. B. J9000x1 unit, 96413. C. J9000x2 units, 96409. D. J9000x1 unit, 96409. Answer: A. J9000x2 units, 96413. This question tests both drug coding, HCPCS Level 2, and chemotherapy administration, CPT. The drug 100 mg and the vial strength 50 mg per milliliter mean that 2 units of the 50 mg J-code are required. 100 mg/50 mg per unit equals 2 units. The administration code is determined by the route and duration. Intravenously and 45 minutes for chemotherapy align with code 96413, which describes intravenous infusion, for therapy, for 31 to 90 minutes. Therefore, the correct coding includes both the drug and the administration. Always verify the drug dosage against the J-code's unit definition and correctly identify the administration type and duration. Question 10. A patient is admitted to an acute care hospital. The attending physician documents a comprehensive history and examination. Based on their assessment, the medical decision-making is of high complexity. What is the appropriate E/M code for the initial hospital inpatient encounter? A. 99,221. B. 99,222. C. 99,223. D. 99,231. Answer: C. 99223. This question assesses the coding of initial hospital inpatient E/M services. The key phrase initial hospital inpatient encounter directs to the 99,221 to 99,223 code series. For these codes, the level of service is primarily determined by the medical decision-making, MDM, complexity or total time spent. The documentation of high-complexity medical decision-making directly corresponds to CPT code 99223. For instance, moderate MDM would lead to 99,222, and straightforward MDM would lead to 99221. Always match the documented MDM or time to the specific criteria for the initial inpatient E/M codes. Question 11. A patient presents with a deep laceration to the arm that requires layered closure. The laceration measures 8.5 centimeters. What CPT code should be reported for the repair? A. 12,004. B. 12,034. C. 12,044. D. 13,121. Answer: D. 13121. This question tests the correct selection of repair codes based on complexity and body site. The keyword layered closure indicates an intermediate or complex repair. The measurement 8.5 centimeters is also important. Repairs on the arm fall under scalp, axilla, trunk, and/or extremities, excluding hands and feet. Simple repairs 12001, 12007 are single-layer closures. Intermediate repairs 12031, 12057 involve layered closure of one or more of the deeper layers of subcutaneous tissue and superficial, dermal and epidermal, layers, or single-layer closure of a contaminated wound. Complex repairs 13100, 13153 involve more extensive undermining, debridement, or involvement of deeper structures. A layered closure often points to at least an intermediate repair, but 13121 is for complex repair of the trunk/extremities, 8.5 centimeters, indicating the trickiness between intermediate and complex, where deep laceration and implied extensive work often push it to complex. Always carefully read the specific CPT descriptions for simple, intermediate, and complex repairs, paying attention to the closure type, location, and size. Question 12. A patient with type 2 diabetes mellitus is admitted to the hospital for pneumonia. During the hospitalization, the patient's blood glucose levels become poorly controlled due to the stress of the infection, and the physician actively manages the diabetes. How should the principal and secondary diagnoses be sequenced? A. J18.9, E11.9. B. E11.9, J18.9. C. J18.9, E11.65. D. E11.65, J18.9. Answer: C. J18.9, E11.65. This question tests the sequencing guidelines for conditions that are interrelated or complicate each other, specifically when diabetes is involved. The patient was admitted for pneumonia, making it the principal diagnosis, J18.9. The key clue is that the diabetes became poorly controlled due to the stress of the infection, meaning the pneumonia exacerbated the diabetes. When a patient with diabetes has a condition that causes poorly controlled blood sugar, the code for the condition, J18.9, is sequenced first, followed by the diabetes with hyperglycemia, E11.65, as per ICD-10-CM guidelines for complications and manifestations. Always ensure that the principal diagnosis reflects the reason for admission, and subsequent codes accurately describe any related or exacerbated conditions. Question 13. A pathologist performs a gross and microscopic examination of a breast biopsy specimen from a single lesion. Which CPT code is appropriate? A. 88302. B. 88305. C. 88307. D. 88309. Answer B. 88305. This question assesses the correct CPT code for surgical pathology services based on the specimen type and level of examination. The key phrase, breast biopsy specimen, immediately directs to the 88305 code level. CPT code 88305 covers surgical pathology, gross and microscopic examination, for specimens like a breast biopsy, where significant professional work is involved. Lower levels, e.g., 88302, are for simpler specimens like appendix or gallbladders, while higher levels, e.g., 88307, 88309, are for more complex or extensive resections like a mastectomy or total colectomy. Always refer to the specific CPT section for surgical pathology and match the specimen type to the correct service level. Question 14. A 72-year-old patient undergoes an inpatient total knee arthroplasty due to severe osteoarthritis. Which ICD-10-PCS approach value describes the typical incision for this procedure? A. 0. B. 1. C. 2. D. 3. Answer A. 0. This question tests understanding of the ICD-10-PCS approach definitions, which can be tricky. For a total knee arthroplasty, the typical incision is made through the skin and subcutaneous tissue, directly exposing the joint without cutting through additional body layers. This type of open incision is defined by the open approach value, which is represented by the character 0 in the PCS system. Values like 1-4 external, 2-4 percutaneous, and 3-4 percutaneous endoscopic describe different access methods, none of which fit a standard total knee replacement. Always remember that the open approach, 0, in PCS refers to cutting through the skin or mucous membrane and any other layers necessary to expose the body part. Question 15. A patient has a benign epidermal cyst on their back that measures 3.0 centimeters. The physician excises the cyst, and the final pathology report confirms a benign lesion. The excision requires simple closure. Which CPT code should be reported? A. 11403. B. 11404. C. 11406. D. 11603. Answer A. 11403. This question tests the correct CPT code for excision of benign lesions. The key phrase, benign epidermal cyst on their back, points to the 11400, 11406 series for benign lesions of the trunk, arms, or legs. The measurement, 3.0 centimeters, is crucial. For excision of benign lesions, CPT codes are based on the excised diameter, which includes the lesion plus a margin of normal tissue excised with it. Although the lesion itself is 3.0 centimeters, the code descriptions for excision of lesions are based on the excised diameter. Code 11403 is for excision of a benign lesion, trunk, arms, or legs, with an excised diameter of 2.1 to 3.0 centimeters. The simple closure is inherent to this code. Always remember that the size for excision codes typically refers to the excised diameter, not just the lesion size, and always choose the code based on the body site and excised diameter. Question 16. A patient is seen in the outpatient clinic for routine follow-up of stable essential hypertension. The physician reviews the patient's blood pressure readings, advises to continue current medication, and documents that the patient is responding well to treatment. What ICD-10-CM code should be reported? A. I-10. B. I-10, Z79.899. C. Z00.00. D. I-10, Z00.00. Answer: A. I-10. This question tests the coding of chronic conditions in an outpatient setting and the proper application of Z codes. The keyword stable essential hypertension indicates a chronic, ongoing condition. According to ICD-10-CM guidelines, when a patient is seen for the management of a chronic disease that is stable and controlled, only the code for the chronic disease itself is reported. There is no need for a Z code for routine follow-up or medication use for a stable condition, as the management of the chronic condition is the reason for the visit. Therefore, I-10 for essential, primary, hypertension is the correct and only code needed. Question 17. A provider performs a Level 3 office visit, 99213, for an established patient. The patient has a new symptom, e.g., persistent cough, and the provider also performs a separate, medically necessary spirometry, 94010, during the same encounter. How should these services be coded to ensure proper reimbursement? A. 99213, 94010. B. 99,213 to 25, 94010. C. 99,213 to 59, 94010. D. 99213, 94,010 to 59. Answer: B. 99,213 to 25, 94010. This question focuses on the correct application of Modifier 25. Modifier 25 signifies a significant, separately identifiable E/M service by the same physician or other qualified healthcare professional on the same day of the procedure or other service. The key clue is new symptom, e.g., persistent cough, and separate, medically necessary spirometry. While spirometry, 94010, is a diagnostic procedure, the E/M service, 99213, was distinct and significant, addressing a new problem beyond the usual pre-procedure work. Therefore, Modifier 25 is appended to the E/M service, 99213, to indicate that it was above and beyond the typical E/M work associated with the spirometry. Always use Modifier 25 when an E/M service is distinct from a minor procedure or other service performed on the same day. Question 18. A patient is admitted to the hospital with a principal diagnosis of acute myocardial infarction, MI. The patient has a history of coronary artery disease, CAD, and also suffers from chronic kidney disease, CKD, stage 3. Which diagnosis should be sequenced as the principal diagnosis? A. I-21.9. B. I-25.10. C. N-18.3. D. I-25.10 with I-21.9. Answer: A. I-21.9. This question tests the fundamental rule of principal diagnosis sequencing for inpatient admissions. The principal diagnosis is the condition chiefly responsible for the patient's admission to the hospital. The keyword principal diagnosis of acute myocardial infarction, MI, directly identifies the reason for the inpatient stay, I-21.9. While CAD and CKD stage 3 are important comorbidities that would be coded as secondary diagnoses, they are not the reason the patient was admitted. Always identify the condition that led to the hospital admission as the principal diagnosis, regardless of other coexisting chronic conditions. Question 19. A patient undergoes an ultrasound of the abdominal aorta, common iliac arteries, and external iliac arteries to evaluate for aneurysm. Which CPT code is appropriate? A. 76,770. B. 76,775. C. 93,978. D. 93,979. Answer: C. 93978. This question assesses accurate CPT coding for non-invasive vascular studies. The key anatomical structures mentioned are the abdominal aorta, common iliac arteries, and external iliac arteries, evaluated for aneurysm. Code 93978 specifically describes a duplex scan of the aorta, IVC, iliac vasculature, and/or visceral arteries, complete study. Code 76770 is for a limited abdominal ultrasound, and 76775 is for a retroperitoneal ultrasound. Codes 93979 is for a limited study. Always consult the CPT index and choose the most specific code that fully captures all the anatomical areas examined during the vascular study. Question 20. A patient presents to the outpatient clinic for a preoperative history and physical examination prior to elective knee surgery. The surgeon performing the knee surgery is not the same physician performing this H&P. How should this encounter be coded? A. Z01.812. B. 99,203. C. Z01.810. D. 99,213. Answer: A. Z01.812. This question specifically tests the coding of preoperative evaluations performed by a physician different from the operating surgeon. The key phrase, preoperative history and physical examination prior to elective knee surgery and surgeon performing the knee surgery is not the same physician, are crucial. According to ICD-10-CM guidelines, when a preoperative evaluation is performed by a provider other than the surgeon, the appropriate code for the encounter is Z01.812, encounter for pre-procedural cardiovascular examination. While the H&P could be billed with an E/M code, e.g., 99,202 to 99,205 or 99,212 to 99,215, the diagnosis for the encounter is Z01.812. Always use the specific Z code for preoperative evaluations when performed by a separate provider. Question 21. A patient presents to the urgent care clinic with a suspected fractured ankle after a fall. X-rays are ordered and confirm a non-displaced fracture of the lateral malleolus. The urgent care physician applies a walking boot and refers the patient to an orthopedic specialist. What is the appropriate E/M code for this urgent care visit? A. 99,281. B. 99,282. C. 99,283. D. 99,284. Answer: D. 99284. This question tests E/M coding for urgent care/emergency department visits. The severity of the presenting problem and the complexity of medical decision-making, MDM, are key factors. A suspected fractured ankle, confirmed by X-rays, the application of a walking boot, and a referral to a specialist indicate a higher level of complexity than a minor problem. Managing a fracture, even non-displaced, and arranging follow-up typically involves a moderate to high level of medical decision-making. This scenario often aligns with CPT code 99284 due to the acute, severe nature of the problem, the diagnostic test, and the management decisions involving a referral. Always evaluate the number and complexity of problems, the amount of data reviewed, and the risk of complications to determine the appropriate E/M level. Question 22. A patient is admitted for chemotherapy for an active malignant neoplasm of the lung. Which ICD-10-CM code should be sequenced as the principal diagnosis? A. Z51.11. B. C34.90. C. Z51.11, C34.90. D. C34.90, Z51.11. Answer: A. Z51.11. This question addresses a specific ICD-10-CM guideline for encounters primarily for chemotherapy. The key phrase "admitted for chemotherapy for an active malignant neoplasm" is crucial. According to ICD-10-CM official guidelines, when the primary reason for an encounter or admission is chemotherapy, immunotherapy, or radiation therapy, the appropriate Z code for the encounter, Z51.11 for chemotherapy, is sequenced as the principal diagnosis. The active malignancy, C34.90, is then coded as a secondary diagnosis. This ensures the reason for the healthcare encounter is clearly identified. Always remember that for encounters solely for therapy, the Z code for the therapy takes precedence as the principal diagnosis. Question 23. A 55-year-old male undergoes a complete diagnostic colonoscopy. A 1.5 cm sessile polyp is found in the transverse colon and is removed by hot biopsy forceps. What CPT codes should be reported? A. 45,378. B. 45,384. C. 45,385. D. For 5378, 45,384 to 59. Answer: B. For 5384. This question tests the correct CPT coding for colonoscopy with polypectomy, specifically when using a hot biopsy forceps. A complete diagnostic colonoscopy is covered by 45378, but when a polyp is removed during the same procedure, the appropriate therapeutic code is used, and the diagnostic code is not reported separately. The keywords 1.5 cm sessile polyp and removed by hot biopsy forceps are critical. CPT code 45384 describes a colonoscopy with removal of a lesion by hot biopsy forceps or bipolar cautery. Even though a hot biopsy forceps was used, this code is used for the removal of a polyp by hot biopsy forceps. Code 45385 is for polypectomy by snare technique. Always choose the most comprehensive therapeutic code that describes the definitive procedure performed, rather than coding the diagnostic scope separately. Question 24. A patient has an initial diagnosis of type 2 diabetes mellitus with diabetic polyneuropathy. How should this condition be coded in ICD-10-CM? A. E11.40. B. G63. C. E11.42. D. E11.9, G63. Answer: C. E11.42. This question tests the understanding of combination codes for conditions with a causal relationship in ICD-10-CM. The phrase type 2 diabetes mellitus with diabetic polyneuropathy indicates a direct link where the diabetes is causing the neuropathy. ICD-10-CM provides combination codes for conditions that have a clearly defined cause and effect relationship. E11.42 specifically represents type 2 diabetes mellitus with diabetic polyneuropathy. It is generally inappropriate to code E11.9, unspecified diabetes, and G63, polyneuropathy in other diseases classified elsewhere, separately when a specific combination code exists. Always look for combination codes when one condition is clearly a manifestation or complication of another. Question 25. A patient undergoes an initial office visit for evaluation of a shoulder injury. The physician performs an examination of the musculoskeletal system, limited to the shoulder. This includes inspection, palpation, range of motion, and stability testing. According to the 1997 documentation guidelines for E/M services, what is the level of examination performed? A. Problem-focused. B. Expanded problem-focused. C. Detailed. D. Comprehensive. Answer B. Expanded problem-focused. This question specifically tests knowledge of the 1997 documentation guidelines for E/M services, which are still applicable for certain services and useful for understanding the historical context and detail levels of examination. The keyword musculoskeletal system, limited to the shoulder, and the listed elements inspection, palpation, range of motion, and stability testing align with an expanded problem-focused examination. A problem-focused exam would involve fewer elements. A detailed exam typically includes more body areas or organ systems, and a comprehensive exam is a general multi-system or complete single-system exam. Always distinguish between the different levels of examination based on the number of body areas/systems and the specific elements documented when applying the 1997 guidelines.